Good afternoon, everyone. Thank you for joining us for our bite-sized lecture today. I'm going to give it another minute before I open up with our remarks from the executive board. Okay. All right, in the interest of time, we'll begin. I do want to open up with a few announcements from the executive board for the Southeast chapter of SCCM. Do you guys know any nurses out there that should be recognized? We are looking for nominations for our for the Barbara McLean contributions to Critical Care Nursing Award, as well as the Chase A. Hall Exemplary Novice Award. Details can be found on our website, but feel free to reach out and send communication nominations to the communications@sccmse.org email. We also have our critical care didactic lecture coming up in May 7th. This will be an in-person presentation, half-day course that will provide CE to physicians, nurses, as well as APPs. So please feel free to reach out and register. The deadline is May 5th as well for that. And before I begin and introduce our speakers today for our bite-sized lecture called Delivering the Unexpected, I would like to open up with our SCCM mission, which is to emulate the SCCM's mission, which is to secure the highest quality of care for all critically ill and injured patients in the Southeast region by providing educational and research opportunities, as well as promoting multi-professional collaboration. Today, we are fortunate to have the team from Northside. First, we have Brandon Frady. He's a critical care nurse practitioner. He's got extensive history and experience with over 20 years of practicing at a critical care provider. He is also serving as an adjunct faculty member at the Georgia Baptist College of Nursing at Mercer University as well. He also serves as Director of Fundamentals Critical Care Support Course and as an instructor for both FCCS and FCCS Obstetrics. We also have Raegan Williams, who is a physician assistant and leader in critical care medicine. She also comes with 15 years of frontline experience, as well as managing complex patients in the intensive care settings. And beyond the bedside, she oversees a team of advanced practice providers and drives professional development initiatives as well in her role. And then finally, we do have Trish, who is a nursing leader and system director for Northside with regard to the women's services there. And with that, I would love to hand over the reins to our speakers. Thank you very much, and look forward to learning a little bit more about navigating obstetric emergencies.
Thank you, Kyle. Can you hear me? I just want to clarify.
Yes.
So perfect. So we're going to talk about 3 particular OB emergencies today. I wanted to start out by speaking for the group that none of us have any disclosures at this time. We are going to talk about preparation, management, and kind of some very specific things in regards to preeclampsia, postpartum hemorrhage, and then maternal resuscitation, kind of the 3 bigger things that we think of. I don't think a lot of people think about preeclampsia in an emergency kind of status, but maybe we'll change our mind about that a little bit as far as the initiation and management. And then again, we'll look a little bit at postpartum hemorrhage and then maternal resuscitation. So we can't really start a obstetrical lecture without talking about some physiologic changes in pregnancy, because pregnancy physiology is very different than non-pregnant physiology. And there are some key things in there that help us as critical care providers be a little bit more aware of some expected changes and when we would intervene or how we would intervene a little bit differently. Probably pretty knowledgeable to everybody. Blood volume changes are significant. Again, I think all the physiologic changes in pregnancy are geared towards delivery, the anticipation of delivery, the things that happen during delivery. And when we think about blood volume, we think about kind of the distribution of the blood volume between the fetus, the amniotic fluid, extracellular and intracellular spaces. And I think one of the things that doesn't always come to mind is there is an associated anemia that goes along with this over time. There is mild edema. There are minimal changes in atrial natriuretic peptide as a result of some vasodilatation that we'll talk about, and really CVP and volume status. The pressures that we would measure generally aren't changed that magnanimously during pregnancy. So when you think about pregnancy and preload, basically vasodilatation, the uterine artery diameter doubles up around 20 weeks. You have things, estradiol, progesterone, relaxin that contribute to decrease in vascular resistance. So what you have is you have an increase in preload. So you have an increase in blood volume. And in order to manage that increase in blood volume, you basically have a decrease in systemic vascular resistance. And those two things together in combination with mild tachycardia, which we'll talk about, are going to be your compensatory mechanisms to this increase in volume. And that volume expansion really kind of peaks or happens at the majority of in the second trimester. And the graphic here kind of shows you red blood cell mass, plasma volume, which goes up quite significantly, and blood volume as well. And a key thing here is that plasma volume goes along with blood volume. So a red blood cell mass doesn't increase. So these patients do have some anemia that develops throughout their pregnancy. Oops, sorry. So plasma volume increases by 10 to 15% between week 6 and 20, and there's rapid expansion until about week 30 to 34. Red blood cell volume increase to a lesser extent. There is a hemodilution which peaks between 24 and 26 weeks. And then in the non-pregnant patient, when we think about volume comparisons, 65 mLs per kilo to 70. In the pregnant patients, 100 mLs per kilo. So the volume goes up quite significantly. And again, the way that's managed is managed with reduction in systemic vascular resistance. So drop in SVR, drop in blood pressure, and an increase in heart rate. So normal heart rates in the 100 range, the low hundreds, and then systolic blood pressures can be somewhere in the 90s. So just those pregnancy changes alone can make things like sepsis and some other disease states, when you compare pregnant and non-pregnant patients, a little bit difficult to pick up on. So what are some of the physiologic effects of that increased blood volume? Well, you have increase in blood viscosity, reduced resistance, aiding in placental perfusion, reducing cardiac workload. Again, total increase in intravascular volume is approximately 50% by near term. Again, that's kind of preservation for blood at the time of delivery. Historically, it was like what I was taught when I started this was 500 for vaginal delivery and 1,000 for C-section. In my mind, now that I practice more consistently, I usually just kind of think of about 1,000 for everybody. And again, that increase in blood volume is to minimize blood loss during delivery. Again, heart rate rises in the first trimester and maxes in the first trimester and maxes out in the third trimester. Average upper limit, this says 95. I'll tell you, my practice says that it's a little bit closer to 100, maybe 105. So again, tachycardia may be a little bit difficult to see. And the graphic here kind of shows you a patient in lateral position versus supine position and kind of what happens with stroke volume. And this plays into cavoatrial compression, which we'll talk about in just a second. So blood pressure and vascular resistance in pregnancy, both systolic and diastolic, fall early in gestation. They remain low in the second trimester and generally start to rise in the third trimester to normal. And the blood pressure is reduced secondary to reduction in SVR. Cardiac output rises between 30 and 50% above baseline. Early pregnancy cardiac output increases as a result of the stroke volume, late pregnancy cardiac output increases as a result of increase in heart rate. And so half of the increased cardiac output happens in the first 8 weeks. So that initial cardiac output is really boosted in that kind of 8-week. And then it starts to slow in the second trimester and fall off during the third and plateau during the third trimester. So pregnant women are dependent on increased cardiac output, not only for delivering blood and supply to the fetus, but also that adequate oxygen delivery to the fetus. And I will say, one of the things is that baby is a huge indicator of what's going on with mom. If baby's having struggles, mom's probably having some struggles, whether or not she's presenting with those struggles as from a physiologic perspective. So maternal dependence upon cardiac output, there's increased metabolic demand, increased oxygen consumption, increased CO2 production, decreased functional residual capacity and increased minute ventilation. They have a decreased PaCO2 and a compensatory excretion of bicarb to manage this decrease in the CO2 overall. They have really high functioning kidneys. Creatinines for these patients should be well under 0.8. So even though the laboratory value is going to not flag it as abnormal, creatinines, pregnant patients have a very high GFR, they clear very well. And so for that reason, creatinines above 0.8 should be very concerning from a renal perspective. Maternal posture and hemodynamics, a supine position creates cavo-atrial compression, and what you have is preload reduction and increase in afterload. So the blood can't get back to the heart and it can't get out. And that can be reduced as much to 25 to 30%. So, having mom lay on the left side, getting off cavo-atrial compression can help with some cardiac dynamics and some cardiac performance, especially if you have someone who is also critically ill at the same time. Just really quickly, some lung changes. Again, there's upward displacement of the diaphragm as the gravid uterus continues to grow. You have a decreased residual volume and functional residual capacity is also decreased. And then you have the components of active labor and laboring. And then there's also increased O2 consumption during that time frame. All of these things to say that the O2 reserve that we normally think about, a PaO2 of 60 and being okay with that, it is not okay in the patient who's pregnant. We would prefer their PaO2s be 70 or greater, and they're more likely to become hypoxemic very, very quickly. So we like their SATs to be a minimum of 94% or greater. And so there are much thinner margins here for hypoxemia and deterioration with the pregnant patient. There are big time things that we have to think about, things like hypoventilation and or apnea or decreased cardiac output. Those things can get you into trouble a lot faster with patients that have the patients that are pregnant, given the kind of physiologic changes and the fact that the margins are much thinner as far as being able to have that bandwidth with hypoxemia and not having fetal distress. Airway considerations are very important from a critical care perspective, given progesterone and all of the other kind of changes that happen from an endocrine perspective with hormones. Airway edema is much more likely in a pregnant patient. Their airways are much more friable. And they have a relaxation of the lower esophageal sphincter, which increases their risk for aspiration. So when we think about airways in pregnant patients, they are a paramount risk for aspiration. 7-0 endotracheal tube is typically the recommendation. You don't want to go in there and this be the first time you've ever intubated a patient because visibility is significantly reduced, as well as all of the tissue is more friable and relaxed. And when you give the patient the sedation, you can lose that airway very, very easy. So this should be your highest trained person to do the airway. Again, minute ventilation, tidal volume increases, so minute ventilation is going to increase. The big thing is that functional residual capacity, or FRC, is reduced by 20%, leading to a very rapid development of hypoxemia. And so they have this increased oxygen consumption, and you have decreased capacity, so the pregnant patients can get very hypoxemic very quickly. Again, just really briefly about acid-base changes. Pregnant women have a compensatory respiratory alkalosis. Their PaCO2 should be between 24 to 27. I probably say that we hang more around the 27 range. Just know a normal PaCO2 on any other patient is not a normal CO2 on pregnant patients. It really should be in that lower range, 27 to 30. I apologize, the slide is in error. It should be 27 to 30. So that results in a pH of 740 to 745 because of the increased loss of bicarb. And so a normal bicarb in pregnancy is 18 to 20. I think the point really to drive home here from a physiology standpoint of view is that CO2s are lower in pregnant women. And so like things like during flu season or when you have a respiratory illness, you may have a CO2 of 35 and you think, oh, that's not bad, or a CO2 of 40 or 45, and that's not bad, when in fact, in a pregnant patient, it's something that's very, very concerning and may potentially even need and warrant endotracheal intubation and management of that patient, because at some point, baby's not going to be able to offload CO2 and is going to get into some distress. So we thought after we kind of give you that information that we would do a little bit of a case presentation and walk you through these three different preeclampsia, postpartum hemorrhage, and maternal resuscitation. So our case presentation is a 41-year-old woman who's a G4 P3 and she's 37 weeks intrauterine pregnant. She comes in with a complaintness of shortness of breath for the last 5 days. Her history of present illness is a fever over the last week with a headache for the last 6 days. She has a past medical history for 3 spontaneous vaginal deliveries. She had a cholecystectomy in the past, and she arrives and her heart rate's 136 to 145. Sats are 93%. Blood pressure is pretty elevated at 210 over 161. Initially, the patient was treated with 20 milligrams of labetalol, followed by 40 milligrams of labetalol, and resulted in a blood pressure of 158 over 107. And her lab results are pending. You've asked for the labs, and they're pending with her admission, on admission. And at this time, Kyle, you can turn it over to Trish. That would be great.
Okay. Let's see. Don't think you all can see my screen.
Yep.
Can you?
Yeah, we can, Trish.
Okay. All right. So we'll just do an overview of preeclampsia. And I want to, first of all, just provide some definitions. There are the hypertensive disorders of pregnancy are divided based on the onset of the hypertension, how long it persists, and whether it's a multi-system disorder. So an individual who has hypertension prior to the pregnancy, or hypertension that's recognized for the first time in the first 20 weeks of gestation, or when hypertension persists beyond the postpartum period, that individual has chronic hypertension. And then you would use the same definitions for essential hypertension. Gestational hypertension is a hypertensive disorder specific to pregnancy that occurs 20 weeks gestation or later, resolves by the time the postpartum period ends, and lacks any of the multi-system sequela that you're going to see in preeclampsia. Preeclampsia is a multi-system disorder with gestational hypertension and either proteinuria or a feature that would represent some organ system involvement, which we'll talk about when we get into the preeclampsia with severe features. And so a preeclampsia with severe features is going to be that preeclampsia disorder with one of the severe features. And those individuals are at higher risk for eclamptic seizure, higher risk for adverse outcome. There are some patients who've had hypertension predating pregnancy, so they're chronic hypertensive, and then they develop preeclampsia, which would be proteinuria or multi-system sequela on top of that chronic hypertensive state, and they have superimposed preeclampsia, and they actually can have higher incidence of adverse outcomes than someone with preeclampsia without the chronic hypertension. Hypertension, by definition, is a systolic blood pressure of 140 or higher, or a diastolic of 90 or higher on 2 occasions greater than 4 hours apart. So it shouldn't just be one blood pressure that you would see in an office or based on position. when a pregnant woman has a systolic blood pressure of 160 or higher, or a diastolic pressure of 110 or higher on 2 occasions greater than 4 hours apart, she's considered to have severe hypertension. And that severe hypertension is one of the severe features for superimposed preeclampsia. Although we talk about having a trend, at least 2 occasions greater than 4 hours apart for the true diagnosis of severe hypertension, when we have someone with severe hypertension, we don't wait that 4 hours. We go ahead and treat and operate off the presumption that this individual has severe features of preeclampsia. The severe hypertension we've talked about is one of the severe features of severe preeclampsia. Other features include thrombocytopenia, which would be platelets less than 100,000, impaired liver function, which would be evidenced by elevation in your ALT or AST about twice the normal range, as long as that's not accounted for by an alternative diagnosis. Severe persistent right upper quadrant pain or epigastric pain that's unresponsive to medication is also a severe feature. Very significant elevations of liver enzymes or this severe persistent right upper quadrant or epigastric pain is concerning for the potential for subcapsular hematoma and may require further evaluation. Renal insufficiency, which is defined by a creatinine of 1.1 or greater, pulmonary edema, new onset headache that's not responsive to a medication or not accounted for by an alternate diagnosis, and then visual disturbances, which would include a scotomata, blurred vision, something of that nature. So any one of those features would give this person a diagnosis of severe features of preeclampsia. It is a multi-system disorder with vascular and hematologic underpinnings, so to speak, which kind of drive the whole pathophysiology of preeclampsia, and the vascular and hematologic changes contribute to the impaired end organ perfusion in preeclampsia. From a vascular standpoint, due to hypertension, there's arterial or vasospasm. That vasospasm may be a compensatory mechanism to wall off the endothelial capillary leak that occurs and the decrease in colloid oncotic pressure. But all of those things combined, the endothelial capillary leak and the vasospasm, can lead to hemoconcentration. So someone coming in with an H&H that might be slightly elevated, a normal hemoglobin is about 11 to 13 in a pregnant patient. We start seeing an initial hemoglobin of about 14 or so, or even on the upper end of 13 point something, that might indicate the potential for hemoconcentration. And then so they can be vascular, intravascularly dry. But that being said, although they can be intravascularly dry, because of the endothelial capillary injury, they are at increased risk for pulmonary edema. So fluid management needs to be judicious. The hematologic changes include thrombocytopenia as a result of increased platelet aggregation from platelet activation and consumption. There is also the risk of hemolysis as red blood cells get forced under these narrowed networks, narrowed vascular networks from the vasospasm and platelet aggregation, which can lead to that hemolysis. And that leads to the laboratory features that are consistent with HELP syndrome, which stands for hemolysis, elevated liver enzyme, and low platelets. And there's some debate about whether that in and of itself is its own disease process or it's a laboratory feature or a pathologic feature of preeclampsia. And then that pathophysiology, the vascular and hematologic changes contribute to impaired end organ perfusion, which can lead to decreased liver perfusion, which increases the risk of subcapsular hematoma from capillary rupture, which also can increase the risk of hepatic rupture. This decreased liver perfusion is what generates the right upper quadrant epigastric pain or the increase in liver enzymes. There are renal manifestations, the proteinuria, the leak of protein because of the glomerular filtration rate, and just the endothelial capillary injury will contribute to that state. And then there can also be impaired uteroplacental perfusion, which can lead to impaired fetal oxygenation, which can lead to fetal distress and also increases the risk for placental abruption, which is when the placenta shares away from the wall of the uterus prior to the delivery of the fetus. It can be a hemorrhagic emergency in and of itself. The complications from preeclampsia stem from this impaired organ system perfusion. Eclampsia is considered another phase of preeclampsia, but it is also a complication of preeclampsia. Eclampsia is the tonic-clonic convulsive phase of eclampsia. Severe features of preeclampsia increases this risk and warrants seizure prophylaxis with magnesium sulfate in that set of patients with severe features. They are at risk for a cerebrovascular accident, which can be ischemic or hemorrhagic. There's also an increased risk of posterior reversible encephalopathy syndrome, acute kidney injury. I've talked about placental abruption, which could be a fetal obstetric emergency, but will also contribute to the increased risk for maternal hemorrhage, disseminated intravascular coagulation as well. I've also mentioned subcapsular hematoma and hepatic rupture as a complication, and then pulmonary edema. Pulmonary edema usually arises from the capillary injury and increased endothelial, increased capillary permeability from endothelial injury. And then if we are not judicious in our fluid management, there is also the risk for fluid overload, which can lead to the cardiogenic pulmonary edema state. So management of preeclampsia begins with recognition of the multi-system disruption of this disease process. It also requires accurate blood pressure measurement because that blood pressure will determine whether she's in the severe range or normal range, which could therefore generate a response from a standpoint of risk for seizures and therefore seizure prophylaxis with magnesium sulfate. Requires early recognition, assessment of the fetus to determine that there's adequate fetal oxygenation. We will keep patients in an outpatient setting or hospital setting depending on severity and what features that patient displays. And the purpose of that is to monitor for disease progression in order to determine the optimal time of delivery to prevent adverse maternal outcome, but also adverse fetal outcome. Antihypertensive medications are indicated when the systolic blood pressure is 160 or higher, or the diastolic blood pressure is 110 or higher. The favored agents are IV hydralazine, IV labetalol, or PO nifedipine. Eclampsia prophylaxis with magnesium sulfate is indicated for individuals with severe preeclampsia or severe features of preeclampsia, should be initiated prior to delivery, continued throughout the intrapartum process, and typically continued up to 24 hours postpartum. I've mentioned the fluid management needs to be judicious. They may require a fluid bolus, but we don't want to give unnecessary fluids beyond what we would need to manage oliguria or abnormal fetal heart rate status. Airway management is another key, also because they have nasopharyngeal edema and because of their risk of failed airway. And then any consultation triggers such as critical care consultation, maternal fetal consultation. At times these patients are also risk for cardiomyopathy and may need cardiology consultation. The blood pressure of 160 or higher for systolic or the diastolic of 110 or higher as a threshold for treatment may be different than what you see in the non-pregnant population. And the reason for a somewhat lower threshold to treat blood pressure is because of the impaired autoregulation. There's already in pregnancy an impairment in autoregulation because of the hyperventilation and elimination of CO2 during pregnancy. And then the onset of severe hypertension can cause a forced overdistension of the cerebral vasculature, putting them at risk for barotrauma. So these individuals are at risk for cerebral hemorrhage at a lower threshold blood pressure than we may see for the non-obstetric population. And that's why we want to treat those blood pressures when they reach those thresholds. Our goal is not a normalization of blood pressure. Our goal is to get the blood pressure out of stroke range. So the goal is to get a blood pressure in the range of about 140 to 150 systolic and about 90 to 100 diastolic. We should continue to treat a blood pressure of 160 or 110 in order to put them out of that risk for intracranial hemorrhage, but you don't want to be so aggressive that you cause them to become hypotensive, because hypotension can have adverse fetal effects. So continuing on with this presentation, I think at this point I'd like to hand over to Raegan. If Raegan wants to pick up with the case study.
Sure, I can do that. And yeah, there you go. Let's see. Can you see my screen?
Yes.
Back
Yeah.
up. Oh, for some reason, I don't have the case in between those two slides. The patient is actually moved to the OR, which I think we saw on Trish's screen before that went off, and on fundal massage following cesarean section, if I'm remembering right, there's a gush of 1.5 liters of blood that comes out. Did I miss anything on that slide, since for some reason it's not in between our two on mine? Okay, so we're moving on at this case, in this case, to talking about postpartum hemorrhage. It's actually the leading cause of maternal death worldwide, and obviously a major cause of maternal mortality. When it comes to defining PPH, kind of as Brandon alluded to before, we've seen these definitions of greater than 500 cc's for vaginal and greater than 1,000 or 1 liter cc blood loss for cesarean delivery. Another great way, and maybe a more accessible way to define this, is the 10% decrease in hematocrit or need for blood transfusion in your pregnant patient. And part of the reason for that, we can see on this slide, I'm just gonna try to hide this really quick, is there's many times in childbirth where you cannot estimate the blood loss. And so different people will tell you lots of different estimations for the amount of blood loss seen on the OR floor here. And so if you think about it from the instance of the 10% decrease in hematocrit or need for transfusion, that's sometimes a better way. When it comes to figuring out the differential that you might be dealing with for postpartum hemorrhage, the 4 T's or 5 T's that are listed here are a good way to go about figuring out what's going on with your patient. So it's tone, tissue, thrombin, and trauma, and then we kind of add other in there. Tone or lack of tone or uterine atony is the most common cause of postpartum hemorrhage, and we'll go into the anatomy and physiology of both a normal and kind of when things can go wrong of the utero-placental unit in the next couple slides. But atony is the most common cause, and that's why we're concerned with things like fundal tone in our postpartum patients to make sure that that is occurring as it should. The next one would be tissue. This is referring to either retained placenta or retained product of conception, or any tissue issues that concern the placenta, such as placenta accreta, where it's embedded kind of too deeply into the myometrium, or previa, where any part of the placenta has embedded covering the cervix. So those can cause obviously postpartum hemorrhage as well as thrombin, and that's dealing with any coagulopathy issues, part of what Trish talked about in the spectrum of preeclampsia, looking at HELLP syndrome, hemolysis that way, low platelet count. This could also be patients who have genetic disorders such as von Willebrand's deficiency, or maybe already were on anticoagulants for something like a PE during their pregnancy. So anything that's going to mess with their clotting cascade. And then trauma, we have things there like uterine rupture, or any trauma to the lower genital tract during either vaginal or cesarean delivery. When you think about throwing other in there, that's uterine inversion or things like AVMs that are thankfully rare, but obviously can contribute to postpartum hemorrhage. Understanding this it's important to understand the normal uterine anatomy, and As we've seen with physiologic changes during pregnancy, when the placenta attaches, the way that it receives blood flow from the maternal circulation is through these spiral arteries that kind of transverse the myometrium, or that layer of muscle there in the uterus. And at the time of term, about 15 to I think 18% of the maternal blood flow, cardiac output is going to the uterus and via these spiral arteries. So as you know, in our patient who's 41 weeks, we're looking there at anywhere between 600 to 900 cc's of blood flow per minute that's going through these spiral arteries. They're dilated at this time period, and that's also that baby can get good oxygenated blood during this time. If things happen the way that they're supposed to, as soon as the placenta is delivered, and this is kind of detached from the endometrium, then there is instantaneous, or should be, myometrial contraction. And what that does is kind of tamponade off these spiral arteries. This also activates a clotting cascade and kind of plugs off any bleeding from these arteries, and kind of starts the process of remodeling back to the non-gravid uterus. You can see here when that wouldn't happen, and you have either outside factors or physical, like tissue factors, that are keeping the myometrium from compressing here, that you kind of still have this wide open hose of these 100, 120 or so spiral arteries that are just pumping blood still into the uterus if that contraction is not happening. So that's why tone is so important, and why we focus on it so much in this process, is if we're expecting or trying to investigate any blood loss. Here's a photograph of uterine rupture. This can occur in the trauma of childbirth, either from a previous cesarean section, or in patients that have had myomectomies for fibroids. Here's an image of a placental abruption, which maternal hypertension can cause, kind of what Trish went over during the preeclampsia. So one really important thing, and kind of what I hope we've been leading to here, is all of the amazing things that happen during pregnancy to get the mother ready to have this blood loss of childbirth can kind of mask when actually it's too much blood loss. So we want to be sure that we're really have our antennae up to make sure we're recognizing postpartum hemorrhage when it occurs. So if we're talking about a gradual maternal blood loss, something that maybe is trauma to the lower genital tract, then the mom can lose, up to 1,500 cc's really without showing us typical signs of hemorrhage that we're used to. If it's acute and we're talking about a tone issue where, she's still pumping 600 to 900 cc's per minute, then that's a little bit less that she can lose acutely, but that's still a ton, to 10 to 15%. So all to say that the signs of hemorrhage can often be absent until you get to a very severe stage, meaning that we're behind a lot of times when it comes to resuscitation in these patients by the time we realize that they're hemorrhaging. So in any hemorrhagic shock pathophysiology, we have our decreasing circulating volume, which leads to kind of shunting to redistribute to our essential organs. And part of that hemodynamic and the body's wanting to go back to equilibrium is that it's in these early times you're going to have the BP maintained. So hypotension is a very late indicator that something is wrong in these patients. You will see a narrowing of their pulse pressure, which is that increased venous return. With the shunting, you'll also see tachycardia, and then their respiratory rate will be increased. And so those are things to look for when you're trying to recognize this. As Brandon said, if the patient has not yet delivered, the fetal heart tones and fetal heart rate pattern can be very instrumental in assessing end organ perfusion. It's just another way that we can see that the end organs are not getting what they need. Obviously, like your normal physical exam, you can look at capillary refill, we can look at their O2. Don't wait for oliguria like you might in a patient who was not pregnant, because due to the increase in GFR in pregnancy, it's going to be a very late sign as well. So the continued progression of blood loss, if we haven't been able to see it, does eventually obviously lead to hypotension, tachycardia, tachypnea, and a mental status change. This slide kind of shows nicely how, you may have your hypotension up here around 10, 20, 30%, and some of these other signs, pallor, prolonged capillary refill. And then you'll have circulatory collapse where you'll finally start to see that blood pressure, and not until much later will you have an altered level of consciousness. So this is a time when you need to, kind of move quickly, and these patients can look good until they're, already down into this 50–60% blood loss, which is quite scary. So moving on to the treatment, once we have recognized, you're going to want to make sure that you use your same ABCDE for these patients, as far as making sure their airway is intact as you would for any patient that you're resuscitating. Then get down to, your breathing, circulation, those sorts of things. For postpartum hemorrhage specifically, we have to know the etiology of what is causing it so that we can treat it effectively. You want to make sure if your facility has massive transfusion protocol, that you're activating that on the early side, and this 1:1:1, just meaning that you're either giving whole blood or you're giving red cells with FFP and with platelets, so that you're not further exacerbating any clotting disorders, because they need the whole complement there. Medical therapy usually will include oxytocics, just meaning medications that can help that clamping down of the uterus and the myometrium, so that you can get that those spiral arteries under control. And then mechanical, there are different ways that you can, and new devices that you can use, balloon and packing, to kind of cause even more clamping down of the uterus from both the inside and the outside. It's important in these patients to, especially because of what we talked about with recognition, to make sure that they, if they need surgical removal, which would mean hysterectomy, that's a decision that's made quickly, because again, you can already be behind when it comes to resuscitation by the time you are involved in the patient. You can use lactated ringers. In general, avoid over-resuscitation with any crystalloid, because blood is what the patient needs. If you don't have an active cross-match, you can give uncross-matched blood. And again, we're going to be transfusing within the 1:1:1 fashion. Allow permissive hypotension there, especially if it's an issue where you can get blood versus crystalloid. And then using that multidisciplinary team approach, where we're involving obviously critical care, and also MFM, and the obstetrical team, the GYN team as well, to make sure that they need hysterectomy or advanced surgical techniques. And then the use of tranexamic acid to treat coagulopathies. Moving back to our patient, after the C-section, she does start shouting that she's unable to breathe, and is attempting to sit up on the gurney, suddenly becomes unresponsive and has no pulse, with a sinus appearing rhythm on cardiac monitor. So I'll give that back to Dr. Frady.
All right, so we'll pick up with maternal resuscitation. This poor patient has really been through the ringer the last hour or so. Can you guys still see my screen?
Yes.
Yes.
Okay, perfect. Thank you very much. Hang on one second. All right. So when we think about maternal resuscitation, we have to look at maternal mortality rates, and you can see the latest data from the CDC between 2019 and 2024. There was this kind of transient period, probably during COVID times, where the rate is up, but we still kind of hang around somewhere around 18 to 20 per 1,000 live births. When we look at that a little bit more in perspective about maternal age, you can see that patients with advanced maternal age have a higher mortality rate for multiple reasons. Again, younger patients 25 to 39 and then under 25 have lower death rates per 1,000 live births. And then when we look at it, again, based upon race and Hispanic origin, that you can see African American non-Hispanics have a pretty high rate. And it was very interesting, and I'm glad to see that in March of 21, the CDC differentiated out American Indian, Native Nascan, non-Hispanic, and they have a very high kind of mortality rate. And again, these are not all associated with postpartum hemorrhage, but they are associated with all cause of maternal mortality. And we'll talk about that a little bit in a minute. So when we think about the characteristics and the outcome of maternal cardiac arrest, resuscitation actually did a review of the American Heart Association with the guidelines. They looked at 462 events, and the median age was 31 plus or minus 7. A third of these patients had no pre-existing condition. So 30% of these patients had no pre-existing condition and had a cardiac arrest event. Nicely, 74% had return of spontaneous circulation, and survival to discharge was about 41%. And if you look at the overall survival to discharge of cardiac arrest patients, it still hangs around 20%, which it has for many, many years. So these patients tend to do a little bit better. These patients tend to have better neurologic outcomes, especially if we can identify the precipitating event for the cardiac arrest and intervene as quickly as we possibly can. So will it happen on your unit, I guess is the question. And when they looked at these maternal cardiac arrest and the locations where they had, a third of them happened in the delivery suite, 21% of them happened in an adult intensive care unit, and then you can see it kind of trails off from there, 13% in an OR, but all the way down into things like cath lab and diagnostic areas and CTs and recovery areas and all kinds of things. And then I think they just felt that there was too many things to list, so then like 5 or 6% were kind of in the category of other. So maternal cardiac arrest, if you have a OB population in your hospital, it can happen really anywhere. Obviously, they're generally concentrated into the delivery suite or the delivery areas, but they can happen anywhere. So when you think about survival outcomes, when they looked at the whole cohort with those that achieved return of spontaneous circulation, 74% survived. Survived in 24 hours, about 61%, and survived to discharge was again 41% or so. So 70% will have return of spontaneous circulation, but only about 40% will survive to discharge. Now, when we take a look, was it a shockable rhythm versus a non-shockable rhythm? And the thing about pregnant patients is they generally have non-shockable rhythms, so asystole and PEA. And PEA is a very common finding for amniotic fluid embolism, pulmonary embolism, all the embolisms that go with our ACLS programs. So non-shockable rhythms, survival to discharge was about 37%, shockable rhythms 33%, and an unknown presenting rhythm. These are generally the patients that come in cardiac arrest, and we don't really know what their presenting rhythm was. So maternal medical conditions that are strongly associated with cardiopulmonary arrest. So who are the patients that are at risk? If you look at this graph, the totality is about 15% are cardiac related. And so I know that this is a younger population, but the population of pregnant patients is getting older over a period of time. And so advanced maternal age is typically somewhere over around 35 to 38 years old. These patients are now coming in, they're having babies later, they're having more historical cardiovascular disease, and so you can see things like hypertension, valvular disease, pulmonary hypertension, ischemic heart. So again, a lot of these patients are going to have underlying cardiac disease, diagnosed or undiagnosed. So some more kind of common causes of cardiopulmonary arrest in pregnancy, some pregnancy-specific causes, anaphylactoid syndrome of pregnancy, or what some of you may know is amniotic fluid embolism, hypertensive disorders of pregnancy, which we talked about earlier, hemorrhage, which we talked about earlier, eclampsia, and then peripartum cardiomyopathy. Causes that aren't specific to pregnancy, asthma, pulmonary hypertension, again, all those cardiac diseases, cerebral vascular accidents, sepsis, thromboembolic disease, and trauma. And then ones that are listed in a bucket of iatrogenic are going to be things like anesthetic complications, mag sulfate toxicity, medication allergies or errors, kind of that catch-all of just the patient interacting with the healthcare facility. So causes of maternal cardiac arrest. Again, the ones in yellow are the pregnancy-related ones. Postpartum hemorrhage is still the driving, or antepartum hemorrhage. When you put those two together, it's a pretty high number. Heart failure is probably the leading cause of maternal cardiac arrest that's not associated with pregnancy. Sepsis is up there as well. So when you look at the data kind of in a global picture, you know, there are the 3 or 4 things that are pretty high on the list that are causes of maternal cardiac arrest. But again, you have to kind of keep your eyes open to, okay, is it a pregnancy associated thing or related thing, or is it really maybe it's an underlying condition? So when we think about maternal resuscitation, it's a chain of survival, just like we have with anything else. The primary providers, you're going to have expert teams, the maternal and neonatal. So now you have additional team members here, and then the critical care component of the care. So in the population of this about 500 patients, PEA was more than half of these cases. So again, when you go back to your ACLS algorithms and managing, and so when you think about the H's and the T's, and you think about all those T's and PE and that kind of stuff, you have to kind of put, when a pregnant patient is in arrest, specifically a PEA arrest, you have to think about amniotic fluid embolism, you have to think about thromboembolic disease, you also have to think about cardiovascular disease. So PEA and asystole were the top two, almost 75–76%, where VFib and pulseless VTAC were much lower. So those rhythms that are like in your face, VFib, VTAC, that we know how to jump on, can be big, that are kind of easy to identify, are very low in the pregnant patient. I will tell you, based upon my experience and what I've seen when I've attended resuscitations with amniotic fluid embolisms that were confirmed on autopsy, they've all been PEA. They've all had some type of kind of neuroaxial discharge and a myoclonus, and they had a normal looking rhythm on the monitor, so people weren't necessarily thinking about, oh wow, is this patient have a pulse? Do they not have a pulse, until they're really very clearly unresponsive. So it can be a little bit of a difficult thing to navigate and negotiate. So how do we treat these patients? The good thing is that this is pretty straightforward for those of us in critical care. It's airway, breathing, circulation. It's all the same things that we think about. Is the patient unresponsive? Are they breathing? And the big difference here is the gravid uterus until the baby is delivered. And so chest compressions are the same place of your hands. They're the same rate. They're the same depth. We don't do anything any different as far as CPR goes. We don't do anything any different as far as defibrillation goes. We don't do anything any different as far as airway management goes. The big difference is manual left uterine displacement. We need to get the baby off the aortocable mechanism. So that fetal aortocable compression, obviously increasing afterload and decreasing preload, and overall decreasing cardiac output. So left uterine displacement is done. until the baby is delivered. You want to have caution when you're doing that. This is an emergency situation, and you will be delivering this baby simultaneously as CPR is evolving. This is not the time where we're worried about sterility. This is not the time where we're getting towels out and we're cleaning. This is the time when you hand the OBGYN an 11 blade and they deliver. Remember, this patient is in an arrest situation, so there's not going to be excessive blood loss during this time frame. There will be amniotic fluid that comes out, and I'll talk about the need and why we should deliver as quickly as we can. We talked about airway management. Again, these are difficult airways. Early intubation by your most experienced provider is key. Defibrillation is the same. Pad placement, energy placement, everything is the same. The only risk that you have is if there's a fetal scalp monitor on, there could be a very low chance of arcing. Thoracic impedance is unchanged during pregnancy, so defibrillation should be done, same doses, same joules, the whole 9 yards. So when we think about cardiac arrest in pregnancy in the hospital environment, again, we have our ACLS algorithm, which we follow. We have the ACLS team, however your team is constructed, but there's also going to be now a maternal and a neonatal component. So the maternal team is going to be the one delivering. Maybe you work in a facility where it's a critical access hospital and it's actually the ER physician who's going to be doing the delivery because there's no OB services in-house or available. So again, it's that you have ideally an ACLS team and this team that's going to do the delivery. And then once the fetus is delivered, then it will be handed off to the neonatal team for management. So performing a perimortem C-section, you're going to hear a lot about perimortem C-sections if you don't already know. I'm trying, I have this own personal campaign where I'm trying to move everybody to say resuscitative hysterotomy. I'm a half full kind of guy with that. So when do we do this hysterotomy, this resuscitative hysterotomy? Is the fundal height is above the umbilicus, or ROSC is not likely to be achieved within 2 to 4 minutes. Ideally, the best outcomes are seen when patients have delivery by C-section within that 4 to 5 minute mark. So what I like to do is we do the first full 2 minutes of CPR, team gets there, try to figure out, is this a reversible cause really quickly? And when we start the second set of CPR, if it's not something likely, then delivery happens kind of at that same time. You're going to maintain left uterine displacement. You're going to continue all CPR measures, doing chest compressions, doing the things that you need to do, giving the medications while the C-section is happening. And really, you're going to do that. And I put a map up here just to kind of say at the site of arrest, in the floor in the ED, in the cafeteria, in the ICU, in labor and delivery, in the labor and delivery OR, wherever it is, it's going to happen at that point. And then once you have stabilized the mom, then the mom can potentially go to the OR for appropriate closure, whatever needs to happen at that point. So why emergency C-sections or resuscitative hysterotomies? When you look at some of the data now, there are not randomized control trials, because who are we going to say do this for this pregnant patient and not this for this pregnant patient? So there's not a ton of cases that are out there, but the cases that are out there, when they looked at surviving moms versus non-surviving moms, the kind of the mean and median ranges in delivery time, what they found was it was statistically significant if we delivered fast. And the faster we delivered, the better things were. And so that kind of 5-minute rule, when they looked at some of the data with that 5-minute rule, 55% of patients that had a perimortem C-section or a resuscitative hysterotomy had substantial improvement in maternal hemodynamics. 32% had beneficial maternal survival with no instances of morbidity, neurologic morbidity, and 60% had increase in cardiac output following delivery, and 67% had return of spontaneous circulation immediately after delivery. So it's great for mom. It's also good for baby, because in this particular study, it resulted in a 74% viable newborn with the delivery. So again, perimortem cesarean delivery, kind of moving it more towards emergent delivery or resuscitative hysterotomy. The goal is to optimize maternal hemodynamics and optimize fetal outcome. So there was a study that they did 15 simulated perimortem C-sections to see participants knew that they would be participating in a resuscitative hysterotomy scenario, as well as the location of delivery. Was it in the bedside or at the OR? So they looked at 14 cases. One that was excluded because it was contaminated. But when they said, okay, we're going to do it in the delivery suite, or we're going to transport the patient to the OR for delivery. When they did it in the laboring room, it was a mean time of 4 minutes and 25 seconds compared to almost an 8-minute mean time. And so that transport and trying to get people where they needed to go, even though teams usually work really, really well and fast together, it still, again, was another 3 or 4 minutes of resuscitation that may have been optimized by just delivery at the time and space of location. So at the site of resuscitative hysterotomy is important. 94% of cases demonstrated that 7% were within the delivery, were within 5 minutes. So in these 94 published studies, when they pooled them and looked at them, only 7%. I think we've gotten much, much better at this over time. I know we have in our specific organization, it takes a lot of practice. And I will stop and look at the chat and see if there are questions. I really want to thank everyone for their time today. Hopefully we've shedded some light on making you just a little bit more comfortable with taking care of some of these conditions with pregnant patients.
Thank you very much, guys. Definitely insightful, taught me a lot of things there. I'm looking at the chat. We have time for maybe 1, maybe 2 questions. Just hold out for a little bit. I do have a question with regard to the perimortem hysterectomy. Is there a minimum gestational period, or is that something as like contraindication or a criteria?
Yeah, that's a great question. Typically, a lot of times we will show up to these events and we won't know gestational age. We may or may not know gestational age, or they may be coming in from the outside and we don't know. In general, the golden rule is if the fundus is at the umbilicus and you can feel it, then we are probably going to do the perimortem C-section for a patient that's in full arrest. If we know that this patient's gestational age is not an age of viability, and it gets a little bit complicated with state laws and some things of that nature. But again, if it's the intent is to save the mother's life, it becomes a little bit more manageable when you're looking at it from that perspective. So if you have no idea and the fundus is at the umbilicus, then you make the assumption and you do the delivery. But anything below that typically doesn't impact maternal resuscitation and maternal physiology that much. And the exception to that would be actually knowing the gestational age.
Gotcha. Thank you so much. So I do not see any other questions in the chat. So I want to say thank you again to our speakers for providing this education, definitely informative and insightful. And thank you for our members for joining as well too. Look forward to seeing you guys at our next quarterly bite-sized lecture. Thank you again.
Thank you.
Thank you.